Okay, everyone, welcome back. We're now going to finish the chapter on antimicrobial treatment. That's looking at controlling microorganisms in the body. Okay, we left off, we had talked about ways that these drugs work. Antimicrobial drugs work, things they can do. We looked at this slide here, things that they do, these mechanisms of action. How they go about destroying or inhibiting the microbe. Now, there are also clinical considerations that should be taken into account when prescribing antimicrobial drugs. The first of those is the spectrum of action. The spectrum of action refers to the number of different pathogens a drug works against. You can have narrow spectrum and broad spectrum. Narrow spectrum antimicrobials work against relatively few kinds of pathogens, sometimes only one. So they're very limited in scope in their spectrum of action. So they only work against one family or one species even. So relatively few kinds of pathogens. There are less side effects. That's the positive, but the negative is this more limited range. You also have broad spectrum antimicrobials. These are effective against many different microorganisms. They can work against, for example, with bacteria, they can work against both gram-positive and gram-negative bacteria. Now, there are more potential side effects. They can lead to more secondary infections, and they can kill your normal flora, which we don't want. But they do have a greater range, and also if, say, a patient comes in with an infection and you don't have time to figure out exactly what it is, you're going to have to go with the broad spectrum. All right? So this diagram just gives some examples, spectrum of activity for some antimicrobial drugs. So these are your drugs here, okay, and what they work against. So for prokaryotes, you can see a drug like this here, polymyxin, is pretty narrow spectrum, where tetracycline, streptomycin, erythromycin, pretty broad spectrum. Okay, and then your antivirals over here. Helminths are parasitic worms, and this is an antiprotozoan or antifungals. So some narrow spectrum, some broad spectrum. So the first thing we want to take into account for a clinical consideration is the spectrum of action. The second one is safety, okay? You need to keep in mind that drugs have the potential to kill your normal microbiota and your normal flora. So disruption of normal microbiota is always an issue with drugs. And the reason for that is it can lead to what's called a superinfection. When you kill normal microbiota, you reduce what's called microbial antagonism. This is the natural competition that results between your normal microbiota, your good bacteria, and the bad bacteria, the disease-causing ones, the pathogens. So think about it. Your normal microbiota are in your body. They're doing fine. They're great. They got a place to live. They got plenty of resources. And now a disease-causing microbe comes right into their territory and starts using their resources, comes right into their backyard. Well, the normal microbiota don't like that, so they compete with them for the same resources. This keeps pathogens in check. You might have pathogens, many people have pathogens right now as part of your normal flora. Something like 25% of people have things like C. diff, Clostridium difficile, as part of their normal flora. Why isn't it causing disease in them right now? Because the other normal bacteria, the normal microbiota, are keeping them in check through that constant competition. So if you destroy a bunch of normal microbiota, say by giving a broad spectrum antibiotic, any bacteria that's either part of your normal flora or an invader, that's resistant to that drug is going to survive and really take off now. All right? So overgrowth of members of normal microbiota that are resistant to the drug. Those that are resistant may be pathogens, and this can lead to disease. C. diff is an example. If C. diff is part of your normal flora, it's notoriously resistant to many antibiotics. So you take a broad spectrum antibiotic. Now remember, that antibiotic, you don't really want it to target your good bacteria, but it's broad spectrum. It's going to kill everything. It's like a nuclear bomb going off. So it wipes out the pathogen, whatever you're taking the antibiotic for, but it also wipes out a lot of your normal microbiota. What doesn't it wipe out? The C. diff that's part of your normal flora, because it's resistant to it. Now, with no other good bacteria to keep that C. diff in check, its population just explodes, and now you have an infection. That's known as a superinfection. This overgrowth of members of the normal microbiota that are resistant. We call that a superinfection. Other examples like thrush. I mentioned C. diff. Okay? Now, if we're going to talk about controlling microbes in the body and antimicrobial treatment, microbes don't just sit around and allow themselves to be killed by drugs. Resistance to antimicrobial drugs is a big problem now, and it continues to grow. Back in 2016, the United Nations General Assembly met to discuss antimicrobial resistance, and this was only the 4th time in the history of the United Nations that a health topic was discussed among the whole General Assembly. Here's a quote from that. Antimicrobial resistance has become one of the biggest threats to global health and endangers other major priorities such as human development. One of the big issues with resistance to antimicrobial drugs is the evolution of superbugs. A superbug is a virus, bacteria, or other kind of microbe, fungi or protozoan, that resists multiple kinds of medicine. Now, here's the issue, everyone. You cannot stop antibiotic and antimicrobial resistance. Antibiotic and drug resistance is inevitable. It's going to happen. The reason is, when you use drugs, it changes the internal environmental conditions of the patient. So using drugs changes the environmental conditions that those microbes live in. When you change the environment, plus the rapid mutation rate of microbes, plus how fast they can reproduce, all that leads to evolution. Microbes evolve resistance through natural selection. Okay? Horizontal gene transfer also plays a role because it speeds up evolution. So you can see here, if we have a population of microbial cells and we constantly hit this population with drugs, some of them mutate and develop resistance to it. Over time, the ones not resistant die off, and we're left with cells that are resistant to it. Okay? This can be a big problem. Resistance in bacteria is often transferred on plasmids. Okay? Remember, plasmids, those little extra pieces of circular DNA not connected to the main chromosome, often carry multiple resistance genes. And the other issue is that resistance to one antibiotic often gives the bacteria resistance to similar drugs. So if it's resistant to penicillin, it's going to be resistant to the semi-synthetics like amoxicillin that are derived from penicillin. Okay? So it's like it says here, it was on a shortcut through the hospital kitchens that Albert here was first approached by a member of the antibiotic resistance. And he says, "Psst, hey kid, want to be a superbug? Stick some of this into your genome. Even penicillin won't be able to harm you. See, notice his gun is DNA. So resistance is a big problem. So how do bacteria become resistant? What changes occur in those bacterial cells that make the bacteria antibiotic or drug resistant? Well, the bacteria can evolve ways to slow or block entry of the drug into the cell. So it can prevent the drug from getting inside the cell and causing damage. They can make enzymes to destroy the drug. They can alter the target on the outside of themselves so the drug can't attach to the outside. And they can make a protein to pump the drug out once it gets inside. That's called efflux. So we see here, if this bacterial cell here is resistant, this is my antibiotic in blue. Well, it could change its surface so that the antibiotic can't attach and get in. If it does get in, we could alter the target molecule. Okay, so alter the target so the drug can't attach. So it gets in, okay, but notice how this is altered right here and it can't attach. That's going to make that antibiotic ineffective. You could have inactivation by enzymes. So the antibiotic or drug gets in, an enzyme that the bacteria makes breaks it down. Or we could pump the antibiotic out. So it gets in, a protein pumps this out. It's called efflux, pumps it right back out. So that's how these bacteria or other microbes become what they do to become resistant. All right? So you have your list here. Slow or block entry here. Make an enzyme that inactivates it. Alter the target, okay, or surface, whatever, and make a novel protein to pump that out. This also shows it. Okay? Now, we can look at an example here. A lot of you may have heard of MRSA, methicillin-resistant Staphylococcus aureus. MRSA, also pictured here, gram stain. Now, what is that? Staphylococcus aureus is the most pathogenic of all staphylococci bacteria. Remember, staphylococci now, round bacteria clustering in sheets. Many strains of Staph aureus, there are many strains of Staph aureus, and they all vary in their ability to cause disease. Interestingly, up to 30% of people have it on their skin or in their nose, their nasal cavity. It's part of your normal flora. Why isn't it causing disease? Microbial antagonism. We just talked about that. MRSA is one of these Staphylococcus aureus strains. The issue with MRSA is it's resistant to multiple antibiotics. We first saw cases of this appearing back in the 1960s, sporadic cases in hospitals throughout the world. 1968 was the first case in the U.S. in Boston. By the 1980s, cases are throughout the world, even outside of hospitals. And up to today, resistance continues to grow. Signs and symptoms include skin rashes, boils, sepsis, abscesses. Necrotizing fasciitis, the bacteria start to consume flesh. And pneumonia can be very dangerous. Terminology used with MRSA, you have CA MRSA. CA is community acquired. That would be if you get MRSA in the community somewhere. You could also have HCA MRSA, health care acquired. This means you contract MRSA, say, in a hospital or other medical facility. And that can break down this way, HO, healthcare onset. So this means you're going to get MRSA in the hospital and start to show symptoms in the hospital. It starts in the hospital, in the healthcare facility. Or it can be HACO, healthcare acquired. You picked it up in the hospital, but didn't start to get symptoms until you were back in the community. All right. So this is just one example here of resistance. Now, what can we do about resistance? So retarding or slowing resistance down. Okay, there are some, remember, it's inevitable. You can't stop it. What we can do is try to manage it. Okay? Number one, maintain a high drug concentration in the patient's body. As you might have heard, people not completing the prescribed course of a drug, especially antibiotics, is a big problem. You're supposed to take that whole Z-Pack, that whole thing over 7 days. These people say, oh, so to feel better, I'll save some for next time. Bad idea. It's allowing resistance to evolve. Okay? Maintain the high concentration. Using combinations of antimicrobials. This is called synergism. Okay? That can at least slow down that evolution. And limiting the use of antimicrobials. You may have heard that antibiotics are greatly overprescribed and they're overused in livestock. This creates prime conditions for evolution of resistance. Encouraging drug companies and laboratories to develop new drugs and therapies. Here's just some recent articles. Bacteria found in ancient Irish soil halts growth of superbugs. Okay? New antibiotics developed by these universities here. Not only are they effective against gram-positive and negative multi-resistant bacteria, they also appear not to trigger resistance when used to treat infection, at least resistance at this point. Okay, next step is clinical trials. Moderna's coronavirus vaccine, okay, and positive news about, this was just recent during the pandemic. So encouraging the development of new drugs and therapies, an issue with that, and an issue with retarding resistance overall, is often drug companies don't have financial incentive. Pharmaceutical companies make most of their money on drugs you take all the time, like statins, like Lipitor, or Prozac, or things like that you have to take your whole life, or at least most of your life. With antibiotics, it's sort of one and done. Okay? So they don't have a lot of financial incentive. Maybe that needs to be changed. Okay? Each of these is going to be effective, especially in combination, to slow down that evolution of resistance. Okay, everyone, that is it for the chapter on antimicrobial treatment. Next time, we're going to look at interaction between microbes and humans, and then get into infectious disease. Okay? So that's it for today. Until next time, have a good rest of the day. Bye-bye.